Lesions in the conjunctiva are varied and more so within the group considered as pigmented lesions. Often ophthalmologists are confused about the diagnosis and management. Pigmented lesions of the ocular surface can be divided into non-melanocytic lesions and melanocytic lesions. We will be discussing the melanocytic lesions, which comprise of complexion-associated melanosis, conjunctival nevus, oculodermal melanocytosis, also known as nevus of Ota, secondary acquired melanosis, primary acquired melanosis with or without atypia, pigmented ocular surface squamous neoplasia, that is OSSN, and malignant melanoma. In this video, we will give an overview of the good, bad, and ugly commonly encountered pigmented lesions of the conjunctiva and their specific clinical features and management. So how do we go about in the first encounter with a patient presenting with a pigmented lesion on the conjunctiva? The following points should be kept in mind. A younger age of presentation points towards a more benign lesion, while an older age points towards a more malignant one. A nevus typically occurs in the interpalpebral area. Fornicial tarsal plica and caruncular involvement should raise the suspicion of malignancy. Benign lesions tend to be bilateral than malignant ones. A cobblestone type of pigmentation is seen in the nevus and a peppery type pigmentation in a primary acquired melanosis. Melanoma, on the other hand, has a uniform dark brown pigmentation. Size is not a real differentiating feature, but documentation is necessary to observe the progression or response to therapy. Exuberant internal vascularity, especially at different levels of involvement, is suggestive of a malignant lesion. Episcleral feeder vessels can be seen in both malignant and benign lesions. However, malignant lesions have a more tortuous feeder vessels than benign lesions. The presence of even a single microcyst is found to be predictive of a nevus which is benign. Benign lesions usually do not invade the cornea. Corneal involvement in complexion-associated melanosis or nevus have a convex configuration, while corneal invasion by OSSN or malignant melanoma have an irregular advancing edge with neovascularization. Episcleral fixity, Ross-Bengal stain positivity, and palpable limb nodes are indicators of a malignant lesion. A thorough intraocular examination is required in all such cases because a surface pigmentation can be an extraocular extension of an intraocular malignancy. So how do we tell the patient that the lesion is benign? If the patient is dark-skinned, presenting with bilateral symmetrical, diffuse, flat lesion which is relatively stationary, then it is a complexion-associated melanosis. If there is history of inflammatory condition or irritant-induced pigmentation, then it is a secondary acquired melanosis. If the lesion is congenital, present in deeper levels, blue or gray pigmentation with associated pigmentation of the ipsilateral periorbital skin, hairline, sclera, and palate, it is suggestive of melanocytosis, that is nevus of Ota. If the lesion is focal, presenting in the first to second decade, and increasing in size or change in color during puberty or pregnancy, and has microcysts with no episcleral fixity, it is suggestive of a conjunctival nevus. If the patient has fair skin, presents with an acquired flat non-cystic lesion, usually unilateral or asymmetrical in bilateral cases with multifocal golden brown, irregular peppery pigmentation, then it is suggestive of a primary acquired melanosis. How do we manage such a benign lesion? Periodic observation with slit lamp measurements and serial photographs is the management of choice. The following points should raise suspicion of malignancy: more than 1 clock hour involvement, multifocal lesions, involvement of the cornea, the palpebral conjunctiva, the fornices, the caruncle or the plica, documented progression, thickening of the involved conjunctiva, personal history of cutaneous or uveal melanoma. Excision biopsy with clear margins with or without intraoperative frozen section margin control is both diagnostic and therapeutic in such cases. When do we tell the patient that the lesion is malignant? If the patient has high-risk factors such as UV or sun exposure, immunocompromised state, HIV positive, post-organ transplant patient with history of smoking, or human papillomavirus infection presenting with unilateral vascularized fleshy limbal mass with gelatinous leukoplakic papillary appearance and has keratin plaques and Ross-Bangle stain positivity, it is suggestive of a pigmented OSSN. If the patient has fair skin, around 50 years of age, and presents with a pigmented fleshy thickened elevated mass, which may involve the bulbar, fornicial, palpebral conjunctiva, and has lesion of tortuous feeder vessels, then it is suggestive of a conjunctival melanoma. The following video shows the management of a malignant lesion using the no-touch technique. A 4 mm clinically clear margin is marked around the lesion. From the clear margin, an episcleral plane is made. The tumor is slowly separated from the conjunctival end till the limbus. An alcohol soak swab is then applied over the clear corneal margin and keratoepitheliectomy of the corneal component is completed. The tumor is then lifted off carefully, making sure there is no residual lesion. A double freeze-thaw cryotherapy is then applied to the excision edge and the excision base. The surface is finally reconstructed using amniotic membrane graft and glue. So despite the varied forms of presentation, it is definitely possible to differentiate the various pigmented lesions and further plan the appropriate treatment.